Let me tell you an interesting story. I call it the Domino Effect. This is a simple case started by a novice surgeon. The capsule is stained with trypsin blue and a needle is used to make a capsulorhexis. The capsulorhexis is made around 4 millimeters, which is really okay in today's times. Now, hydrodissection is attempted, which is complete. You can see the wave. The trenching now begins. A divide and conquer technique will be attempted in this case. Phacoemulsification is begun and nice grooving is done. Now, when the surgeon attempts to chop and inserts the side instrument into the side port, there is a large leak at the side port made, which is larger than what was necessary. Rotation is attempted. The nucleus rotates pretty easily. The second surgeon now takes over, who is more experienced than the novice surgeon. The surgeon continues to phacoemulsify. The pupil at this point is well dilated. Lots of attempts are being made to hold the nucleus and chop, but all the attempts are failing. There is no point where the nucleus can be held and chopped. The nucleus is piecemealing away as the surgeon tries to hold and chop the nucleus. After multiple such attempts to hold the nucleus and crack it, the nucleus is now on its way to form a crater. So let us understand why the crater is formed. One is of course a soft cataract, second a brand new tip, third high vacuum setting or not embedding the tip well into the nucleus. Now an experienced surgeon takes over the case. The first step is to inject intracameral epitrate in order to dilate the pupil, which has come down because of multiple attempts to take the nucleus. Now the experienced surgeon tries again to do a bevel down technique in order to occlude the tip. Note the areas which are showing a clear glow, which means that the epinuclear plate is now exposed and the areas are very thin. More attempts are made to hold on to the nucleus. At this point we can see that the nucleus is being rotated in order to find an area where we can embed the bevel down tip of the phacoprobe. There are multiple areas where a clear glow can be visualized through the thin epinuclear plate which is now exposed. More attempts are made to occlude the tip of the nucleus, and every time the nucleus slips away and cracking is incomplete. Further attempts are made to occlude the tip of the nucleus, and that just leads to piecemealing of the nucleus. The heartbeat of the surgeon rises at this point. So the struggle continues and the nucleus is rotated further in order to find an area where we can embed the tip. Finally the tip is embedded at a point, and here we can see that the nucleus slips away and we get a clear glow. Now we are sure that there is a PC rent at that point because of the beautiful glow that we can see from the posterior. After noting the PC rent, all steps are taken in order to ensure that the PC rent doesn't extend. We fill the bag up with viscoelastic. We make sure that the nucleus is brought out into the anterior chamber and emulsified in order to avoid it from sinking. It is important to ensure that the nucleus is brought out into the anterior chamber and emulsified so that the PC rent does not extend from multiple attempts which are made to occlude the nucleus. We are attempting to take the nucleus out into the anterior chamber, but because of the small capsulorhexis, it is proving to be difficult. So we are extending the capsulorhexis, which was around 4 millimeters to begin with. The bag is filled with viscoelastic and a forceps is used to enlarge the capsulorhexis. Now we are attempting to bring the epinucleus into the anterior chamber so that we can deliver it out, or we can phacoemulsify it without allowing it to sink. But the inevitable happens and the epinucleus drops into the posterior chamber. So primary anterior vitrectomy is performed by the surgeon under triamcinolone, and finally the case is handed over to a VR surgeon, who is the fourth surgeon who steps in to save the case. The fourth surgeon, that is the VR surgeon, now takes over and visualizes the epinucleus in the posterior clearly. Fragmentome is used in order to take care of the epinucleus and few bits of cortical matter which may have entered the posterior chamber. Because we had an intact capsulorhexis margin, we insert a 3-piece IOL into the sulcus, rotate it in place, and then do an optic capture With an optic capture, we ensure that the IOL will be safely in the sulcus, supported by the intact CCC margin. With past experiences in mind, the surgeon moves on to the second case. Here, we have a small pupil to begin with, which is around 5.5 mm. Owing to this, the rhexis is also equally small. After a successful hydrodissection, we move on to phacoemulsification. As we can see, it is a deja vu situation, but the surgeon is already prepared from past experiences. A crater is beginning to form, so we should be alarmed. Now, what is our next step? We can either decide to use a pupil expander like a ring or a hook, or viscodilate the pupil, or else continue to struggle in this manner. But if we use hooks, how do we place them? Let's see. Since pupil expanders like rings give us limited exposure, we decided to go for hooks. Intracameral drugs and viscodilation did not help much. After placing the hooks, we could visualize the CCC margin and we got a better exposure to the nucleus. We attempted to hold the nucleus and crack it once again, but the crater had already been formed and holding and cracking was not feasible. At this point, we decided to remove the nucleus out into the anterior chamber using viscoelastic. We rotated it and brought it into the anterior chamber for easy exposure. Phacoemulsification was attempted. The nucleus was engaged. Careful phacoemulsification was completed. Bit by bit, the nucleus was emulsified. Care was taken not to allow any leakage from the chamber, hence a side instrument was not used. After successfully completing phacoemulsification of the nucleus, the epinucleus was then cleared out and a cortical cleanup was also done. A PCIOL is injected into the bag. So in conclusion, when you have a soft cataract, it is wiser to have an older tip. Always have low vacuum settings, have dilating drugs ready on your trolley, and if nothing works, use hooks instead of rings for better exposure to visualize up to the nucleus equator for safe phaco and to avert crisis. Thank you.